Hey guys, and welcome back to the Intern Bootcamp series. In today's video, we're going to talk about discharge summaries, what to include, and how to make it super useful for when the patient leaves the hospital. The main lesson I want you to learn from this video is identifying, is the patient actually ready for discharge? So it's things like identifying if their pain is well controlled. They can't be on IV pain medication. Are they tolerating a diet, or is there a means by which they can get nourished? Are they ambulating, or per physical therapy and occupational therapy, are they recommended to go to a rehab instead? Are they voiding? Are their vitals stable? Are the labs okay? Is there anything else that we're concerned about from a surgical team perspective? And are they on any oxygen? And there are some things that you can do. Sometimes some patients get really decompensated in the hospital and they might need to go on home oxygen. But the first thing we need to identify is, have they met all of these hospital milestones and are they ready to go home? Now that we've clinically identified the patient that needs to get discharged, let's go through routine discharge paperwork. Let's go to the discharge tab. Let me tell you, I absolutely love this tab. This shows you all the milestones and all the things that you need to do prior to discharge. This isn't really applicable to every patient, but there are a few things that applies to everyone. And really, there are three main components of a discharge. Number one is the discharge medicine reconciliation. So you need to ensure that the patient has the appropriate medication to go home on. These are all the hospital problems that the patient dealt with, and you write down what's active and what's being resolved. So it helps with different admissions, it helps us identify what's going on with the patient, and also for outpatient follow-ups. You can also pick the severity of the condition. Next is the medication tab. When it comes to continuing chronic home medications, I want you to think about whether this patient does have this issue leaving the hospital or if they don't. If it's something that was resolved during the hospitalization, then they wouldn't need that medication anymore. So this is just an example, but if someone has problems with their gallbladder and they were given ursodiol, for example, and their gallbladder was removed, they don't need that medication anymore. So that would be something that would be discontinued. Otherwise, I tend to continue the rest of the home meds, and if they ask any questions about it, I usually defer to prescriber, so the most appropriate person decides what to do with that medication. With anticoagulation, particularly on surgical services, particularly after a procedure, some surgeons would prefer delaying restarting the medication, so you can actually edit that and modify the start date. Usually with everything else, I continue the medication, and if they ask you additional questions about it and it wasn't a medication that was prescribed during this admission, I say defer to the prescriber. So the most appropriate person decides if the patient needs to continue that medication or not. With regards to the hospital orders, you always want to stop IV medication, unless the person is going to a rehab facility where they can give IV medication. But if the patient is going home, they definitely will not be doing that. If someone is to get discharged on a bridging medication, so some patients get discharged on Lovenox for a month if they had cancer, or sometimes to bridge it back to the warfarin, then they would need to get Lovenox or injection education in the hospital, or insulin injections. If insulin was started on a hospital visit, you would need to get education for how to use it. From the admission meds, I tend to review everything. So levetiracetam or Keppra, it's an important seizure medication. You do not want to stop seizure medications, for instance, but it is an IV form, and that isn't something that the patient can take at home. So I've converted it to a oral format. I did make an error over here, so Vimpat should have been converted as well. And then antihypertensives, I usually continue them on discharge, and I get them to either follow up with the PCP or the cardiologist, whoever advised them to take it. Glucose medications, I usually continue it on discharge, and we tend to hold it prior to admission, and that is going to be in the next video. Some patients on our services are discharged with feeding tubes, and for patients who are discharged on that, they would require tube feeds. So this is what my screen looks like. I usually copy and paste the orders from the dietitian's note and paste it as free text.
and I order that for at least 30 days. Pain meds is a really common medication that we give post-operatively. So usually what I do is I look on the chart to see how much of the pain medication they get. So for example, if they got IV pain meds, I cannot discharge them home because I don't see how it would be easy for the patient to control their pain when they're having that. We do not continue PCAs on discharge. With other oral pain meds, for example, oxycodone, if the patient had one tablet daily, then I would give them enough so that they could get one tablet daily on discharge. But also depending on the procedure, for example, if the patient had a vascular procedure, they typically have a relief of pain once they get blood flow to their feet. So they don't usually require heaps of pain meds. So that's something I would also evaluate when deciding for how long to give them the pain meds. Now I'm just showing you guys pain medications. Hydromorphone is something that you can also give patients, but always, always, always never forget to give them a bowel regimen. It's usually Colace that I would give with narcotics, but really you give any stool softeners because they can get constipated. Next, you want to ensure that this is the correct pharmacy to send the prescriptions to. Otherwise, when you're on call, you will get paged a million times about it. With discharges, you always want to order some follow-up appointments. If the person required cardiology to see them as an inpatient, or endocrinology, or really whichever service had to see them as an inpatient, whether it's for uncontrolled sugars or whatever it may be, you would continue a follow-up as an outpatient, and we always, always, always get a follow-up visit for a post-op check. Then you can put a discharge order in. Another thing that I really like doing, particularly if I'm anticipating that a patient is going to be discharged over the weekend, is putting in an anticipated discharge order. It is not shown on the screen, but it really helps any teams involved in discharging, particularly if social work or case management is involved in discharging a patient, to organize that patient for the weekend. We usually have less coverage of every team over the weekend, so it just makes everyone's life heaps easier. The discharge order is placed for illustration purposes. In real life, you would complete every aspect of the discharge and then place the discharge order. One of the main things in a good discharge is the discharge instructions. The goal is you want to answer all the questions that a patient may have prior to them leaving home. And we're going to use a cholecystectomy as an example. Typically, I write what happened during the hospitalization if they want to explain it to their family members. I then go into activity instructions. Many patients have heaps of questions about what they can do, showering, how much they can lift. I want to remind them that you don't drive with narcotics. Diet instructions are extremely important. If a patient had a change in their diet, like if they need to be on full liquids for a while or a bariatric diet, we also give examples of what they're allowed to eat and how easy they should go with it, or how many ounces they're supposed to drink. I also like mentioning what they've been closed with, so if it's surgical glue, staples, steries, and how to take care of that. It's always good to mention what they can take for pain and what we've prescribed for them. And then finally, you want to give them some precautions if they're feeling unwell afterwards to come to the emergency department. And you want to give them a phone number to the hospital or a phone number to the surgery clinic, so they have someone that they can reach immediately at any given time. Another really important thing as part of a discharge is the discharge summary, particularly when someone has been hospitalized for a very long time, number one. And number two, whenever a person gets readmitted, a really good discharge summary makes everyone's life easier. The discharge summary tells a story of the hospitalization of the patient, things to expect, things that happened, any important and pertinent events, any teams that were consulted. So as you can see, this is the generic template. You see consulting teams, reason for hospitalization, operations, procedures during the hospitalization, hospital course, transitions of care and critical issues. If anything profound has changed since the hospitalization, you know. Labs and procedures, where the patient is going to, what was their last physical exam. And this is important if the patient had a drain, for example, and it changed color, or they had a change in their baseline neuro exam. All of these things are super relevant. In this section, if you have a really good discharge instructions part, you can also erase this and put that instead. but it has some of the same questions: wound care, diet, activity, all these things to anticipate after a patient leaves the hospital. And then discharge medication and future appointments. Usually what I tend to do, particularly if a patient's getting discharged over the weekend, or if I'm anticipating they're going to get discharged on a day that we may potentially be busy, I tend to organize the discharge summary and discharge instructions early on. The advantage of this is you just have to do the medicine reconciliation, sign that for the discharge summary, and then put the date and you can sign it. It saves heaps of time, particularly on a really busy day. So here's an example for you guys for the cholecystectomy. The patient underwent uncomplicated laparoscopic cholecystectomy for symptomatic gallbladder disease. I typically include if it's elective or if it was emergent. Post-operatively, recovery was uneventful with stable vital signs. Adequate pain control, tolerance of diet, successful ambulation. The patient was discharged home in stable condition with routine post-operative instructions and follow-up arranged. So you read this and you know that this was a routine bread and butter cholecystectomy case. So I'm just sharing it right now. This is what it looks like when it's ready to go for the weekend team. And again, I really love this discharge tab because you can see the things that have been achieved. Sometimes, and this may not be pertinent for this case, we get case management involved. So if physical therapy or occupational therapy deem that a patient needs to be in a rehab facility for additional strengthening, or if for whatever reason they have complex wounds that cannot be tended to on their own at home, or their family members cannot look after them, they would need to go to a skilled nursing facility. Or sometimes if they have tube feeds that need to be delivered at home, the case management team usually organizes for additional equipment, wound vacs, to be sent to their home.
Alrighty guys, hope you enjoyed that video. Comment below if you want any other tips and tricks for the intern workflow, and stay tuned.